Hi everyone, welcome back to another episode of the Breast Cancer Physio. I'm your host Jen McKenzie, Lymphoedema physiotherapist and ESSA accredited exercise physiologist. I just want to start this video off by saying Happy New Year to everyone. I hope you all had a really wonderful Christmas. I can imagine that going through breast cancer over Christmas mustn't be easy for those of you who are going through active treatment still. And particularly on top of COVID, we've all had such a tough 2020, some more than others, but I really hope that 2021 is going to bring back a lot more nice things. I know we're not past COVID yet, but hopefully next Christmas will be a lot nicer than the one just passed. So Happy New Year to everybody, and I hope you're all in a really good place to start off the new year. So in this video, I'm going to be talking about a really common topic that occurs to so many of my patients going through breast cancer that I just had to do a video on it. This topic is, why does my shoulder hurt after breast cancer? Now, we're not talking about the type of shoulder pain and stiffness that you can get just after you've had breast cancer surgery. We're actually talking about something way more specific that not many people may have heard about. It's called shoulder bursitis. Some people, when they hear that word, might go, oh yeah, I've heard about that before. They might not have even had shoulder bursitis. You might have had hip bursitis or knee bursitis. So bursitis in itself is a really common problem, but particularly I've seen of late that for patients going through breast cancer treatment, bursitis can be incredibly common and problematic in the weeks and months following active treatment. So without further ado, if you enjoy this video and you would like to see more, then please give it a big thumbs up, subscribe to my channel, which is completely free, and leave a comment in the section below if you have any questions on bursitis or any questions around breast cancer in general. All right, so first of all, let's talk about what is bursa. So before we actually get into bursitis, let's just talk about what is bursa. So the bursa we're going to refer to in this video is obviously the bursa that exists in the shoulder. So there's bursas all over our body, and bursa is a normal structure in the body. It's a little fluid-filled bubble that usually lives between a bony prominence and a tendon. And the job of the bursa is actually to stop the tendon rubbing on the bony prominence. So you'll usually find bursa where there's a bone and a tendon together, and the bursa's job is to basically make it smooth between those two structures. So you've got bursa, like I said, in your knee, hip, shoulder, ankle. There's quite a lot of bursas all over your body. So they're normal, but the shoulder bursa lives on the underside of this bony bump, which is the extension of your collarbone. This little point here is called your acromion. And then you've got the head of your humerus, so the ball of your humerus, and then the acromion, or the end of your collarbone, and the bursa lives in between those two structures. So as you can imagine, if this structure becomes inflamed, so it's already quite a small little structure, if that gets a little bit of inflammation in it, when you go to lift your arm up, the space between the acromion and the humeral head, so the extension of the collarbone and the top of the shoulder bone, when you lift your arm up, that space becomes smaller, and you can pinch a structure, being the bursa, that is already inflamed and already painful. So hence why a lot of the time when people get shoulder bursitis, lifting anywhere above 90 degrees shoulder flexion or shoulder abduction, which is out to the side, can become quite painful. Let's just go on to talk about what is bursitis. So essentially we talked about the bursa being a little fluid-filled bubble. Anything that ends in the word itis generally will mean it's inflamed. So if you have heard the word appendicitis before, that literally just means inflammation of the appendix, in the same way that bursitis means inflammation of the bursa. Let's go on and talk about how does it actually present. So what does someone who has bursitis come in reporting? So generally speaking, people will come in and say geez, I haven't really done anything to my shoulder, but it's become really sore. And I think this is the first thing that starts to confuse a lot of people, is they haven't had a fall or a trip, or they haven't reached out and sprained their arm. They literally just start developing shoulder pain for no particular reason. This isn't always the case though, guys. Like, there are circumstances by which someone can fall and traumatically irritate their bursa, but most of the time bursitis seemingly comes out of nowhere. I think that's a lot of the reason why it does get misdiagnosed early on. A lot of people mistake it for a rotator cuff problem of the shoulder, which is usually not the case. In my clinical experience, bursitis is way more common than any sort of full-blown rotator cuff injury causing problems. That might differ to other physiotherapists' experience, but that's certainly been my experience in the last 14 years of being a physio. I see bursitis multiple times a week, and I might see a rotator cuff tendon problem that's genuinely the root cause of that person's pain, maybe once or twice a year. So let's talk about what other symptoms the person with bursitis will report. So they'll often say they can't lie on that side at night. So if they roll onto the shoulder that has bursitis, they quickly get off it because it starts to hurt the shoulder. They might even find that holding onto a steering wheel for a prolonged period of time, say 10 or 15 minutes or longer, will irritate that bursitis type pain. Other things could be, like I said before, like reaching for something in an overhead position, even putting on a shirt, so sliding your arm through a blouse, reaching behind your back. This particularly applies to women, of course, because of things like doing up a bra. Reaching behind you, say if you're in your car and you reached behind you. And then also things like if you were to pick up, say, something mildly heavy with your arm extended, so if you were picking up a kettle full of water, that might irritate the bursa as well. So there's quite a lot of things that are able to irritate the bursa, but as you can see, they're quite positional. So if you stay out of those positions, a lot of the time your shoulder won't hurt. It's only generally when you actually get into those positions that the shoulder can hurt. In saying that though, guys, keep in mind there are grades of bursitis. So someone can have really mild bursitis and they might only tweak that or aggravate that pain in a very specific position. And other people are walking around going, I wish I could put a sling on my shoulder because it is killing me. So there's more extreme versions of bursitis. Generally, to me, that shows that the level of inflammation in the bursa itself can vary quite a lot. And certainly the radiologists who I work with to treat bursitis will tell me the same thing. Sometimes they will ultrasound people with bursitis and one person's got a very mild bursa inflamed, but then other people have got a ton of fluid that is inflamed in the bursa. So keep in mind there's varying degrees of how this condition presents in terms of its severity. Let's move on to how it's diagnosed. If I suspect that my patient might have shoulder bursitis, I'll generally send them off for an ultrasound scan. That's usually the only scan I really need to do to confirm if bursitis is there. If there's anything else though that I want to eliminate, like fractures or frozen shoulder, then we might have to do other things like MRI or X-ray. But if I'm very confident that this is most likely a case of bursitis causing the patient's shoulder pain, I will send them off for an ultrasound scan. The only caveat I'll put on this section, guys, is the fact that, make sure you're going to radiology clinics that have got a good reputation. There's been plenty of circumstances by which I've been very suspicious someone's had shoulder bursitis, have sent them off for a ultrasound scan. Ultrasound scan has come back completely clear. So what they will report is no abnormalities detected, or NAD, which I sometimes will send my patients for a second opinion at different clinics. And sure enough, there's been a number of cases by which people have come back to be told that they do have shoulder bursitis. Now, the other thing to note here, guys, is that if you went and got an ultrasound scan, because there's a few things I've said in this video already where you're like, hang on a minute, that sounds like my shoulder, and your scan does come back clear, you have no problems on your ultrasound scan, and you're happy that the quality of the radiology clinic you've gone to is good, happy with the radiologist who's written the report, don't feel like you really need a second opinion, you might just have a tight shoulder. There's plenty of circumstances as well by which, particularly for people people who have gone through breast cancer treatment that you might just have a really tight shoulder or stiff rib cage or referred neck pain that is causing shoulder problems. So just because your ultrasound scan is clear doesn't mean it's always a problem. This is a really important topic to cover in this video, guys. So why does shoulder bursitis occur? Particularly, why does it occur for patients so commonly after breast cancer treatment? So whenever people go through treatment for breast cancer, they generally will have a combination of surgery plus or minus chemotherapy plus or minus radiation. Through that entire process, particularly from the point of surgery, we tend to protect the chest wall. So if you've had a lumpectomy or a mastectomy, you'll tend to protect this region. And when you protect an area, you'll tend to not use it as normally as you would, which leads to wastage of muscle. Some people might have heard the term muscle atrophy. It's almost impossible to avoid after you've had any sort of major procedure. And it doesn't even matter if you've had just a lumpectomy and no lymph nodes removed. This can still happen to patients who have only just had a lumpectomy. And it certainly seems to occur for a lot of people who have an axillary clearance or sentinel node biopsy. I don't know why, but the scar that is left after axillary surgery is often the most tender of the lot of them. So I think there's a combination of emotional protection of this region plus the tightness and stiffness that's left over following scar tissue and just surgery in general. So protection leads to muscle wastage, which then ultimately means that you have got a tight, weak area starting to form. So that's okay when it's in the first couple of weeks after your surgery or you're going through chemotherapy and you're just still getting everything moving. But what always happens to people after breast cancer treatment is that at some point they get back into normal activities of living, like moving gardening pots, putting the clothes on the line, carrying shopping bags inside, picking up grandkids, washing the car, you name it. And all of a sudden, these activities that were considered normal to you before your breast cancer surgery, you're now doing them with a weak, tight shoulder. And that's enough to kick off bursitis. I see it all the time. It is unbelievable how common it is. This is why I wanted to do this video for you guys, because I want to get the word out there that just because you've got shoulder pain after breast cancer doesn't mean it should be considered a new normal. It might be bursitis, and if it is, it can be treated. So how do we actually treat shoulder bursitis? There's three main things we do to treat shoulder bursitis. The first one is a cortisone injection. Now, if you've seen my other videos and if you're relatively savvy with education around lymphedema risk or lymph node removal, you'll certainly start to think that, hang on a minute, she's just told me to go and get a cortisone injection on my shoulder, which could be the side that has had lymph nodes removed. If it's the side that's had lymph nodes removed, I'm going to go into why it's not necessarily a bad move to get a cortisone injection if you've got shoulder bursitis on the side that's had lymph nodes removed. I'm going to come back to that point in a minute, guys, so just hang in there and I'll explain why it's actually better to consider a cortisone injection than to write it off. But just to cover the treatment side of things, cortisone is the first thing I like to get my patients to do who have got bursitis, because we need pain control before we can go on and do any major strength work. So, and I'll explain that as well in a minute. So we want to consider a cortisone injection, but one that is done by a recommended radiologist in a good radiology clinic. Again, I can't tell you the number of times I have seen patients come to me who have had shoulder bursitis, who have gone and had a cortisone injection that has not been performed well, and they essentially end up going, well, I'm not going to go and do that again because that was useless. That injection did nothing. Or they'll say things like, oh, that only lasted for a couple of weeks or a couple of months and now it's back again. It's very much to do with the fact that they haven't had good education around, say, a follow-up injection that's usually required for most patients who get bursitis in 6 to 8 weeks following the initial injection. Because when you have a cortisone injection, the first cortisone injection usually only takes the level of inflammation in that bursa, I find in my clinical experience, down by about 60 to 80%. So just one cortisone injection doesn't necessarily eliminate all of that inflammation in the bursa. And this is usually why cortisone, I find, gets a bad rap. Cortisone I don't use for every single condition on the planet, far from it. It's always horses for courses when it comes to what treatment tool you use for what problem. But when it comes to shoulder bursitis, it's rare that I've found someone has recovered from shoulder bursitis without a cortisone injection. But it's got to be a cortisone injection that is performed well. So make sure you get good recommendations, personal recommendations, either from your local doctor, local medical team, or even friends and family who've had a good experience with cortisone. Usually the bad experiences come off bad radiology clinics, or just, radiologists who are doing them really quickly and don't give you any education as to what should follow the cortisone injection. For example, in the 7 days after a cortisone injection, don't go and get any physiotherapy done on your shoulder. Let the cortisone do its job and get in there and de-inflame that area. Don't go doing anything excessively vigorous like climbing a mountain or doing cartwheels or picking anything up heavy. Let the cortisone do its job for that first 7 days. Go and see your physiotherapist about a week or so after you've had the cortisone injection, and then they can guide you as to when you might need a follow-up injection. As I said before, usually I find 6 to 8 weeks down the track is when I like my patients to go and have a follow-up injection. And they might not all need it, by the way. Some people need a follow-up injection, but a lot of the time people don't even know they need a follow-up injection. There are some people who have one injection and then they're fine, they don't need anything else. So cortisone is the first treatment technique that I will use. Obviously it's not me personally doing the injection, it's a radiologist. And just as an example of good radiology, there is only one radiologist on the entire Sunshine Coast at the moment, where I'm filming from in Queensland in Australia, that I send all of my patients with breast cancer to, or any of my patients for that matter, to get cortisone injections done. And it's because of the way he performs that technique, the care he takes, and the education he gives the patient around what's going on. Very, very important point there. So the second treatment technique we use, and we can get this started sometimes even before we do a cortisone injection, is physiotherapy. So generally speaking, I'm starting to work on all the tension around the shoulder, if there's any scar tissue from breast cancer surgery, if there's any tension around the shoulder muscles, if there's any tightness or stiffness, say in the rib cage or the neck, that's influencing the way the shoulder moves. So physiotherapy is sort of the other half of the treatment, when it's compared in context to the cortisone injection. So those two things I find are quite vital to get the ball rolling, to get the pain down for the patient, because the third treatment technique, which hopefully will reduce your risk of bursitis coming back again down the track, is strength work. Now, I never get any of my patients who've got bursitis, unless there's extenuating circumstance, and I can't even think of an example of that at the moment, but I never get my patients doing strength work when they don't have pain control around their shoulder. So once you've got that cortisone, which should de-inflame the bursa, because that's the root cause of the problem. You've got an inflamed bursa, which is why, physiotherapists shouldn't actually go and try poking on an inflamed structure, because they're only going to make that worse. The bursa itself in the shoulder is way too deep for us to actually physically touch anyway, and we wouldn't want to do it even if that was the case that we could actually get our fingers on it, because massaging into that area, which we can't touch through our own massage because it is too deep, is not what we want to do. So when we talk about strengthening, we want pain control first, which usually comes through some manual therapy, through physiotherapy sessions, so massage, mobilization techniques, then the cortisone in combination with physiotherapy. Once you've got pain control and a little bit more freedom around the shoulder, that's when you can usually start your strengthening exercises. The reason I bring strengthening exercises into this treatment as a long-term factor is because, generally speaking, the reason the person got the bursitis in the first place was because the shoulder became tight and weak. You could probably even add postural changes to that, particularly for patients after breast cancer. There's another video I've done which talks about improving your posture after breast cancer. I'll just put a little tag to that video up above me now. And the reason that posture changes after breast cancer is also driven by emotional, mental, and physical factors. A lot of women go from having breasts to having one breast removed or no breast removed, or both breasts removed, I should say. And, you know, women are used to having that shape in front of them. And if that shape all of a sudden changes, that can make you cave forward, which ultimately puts your shoulder in a biomechanically poor position. The other reason, of course, that posture changes is because of physical reasons. So, people will get weak and tight here, and that includes your core and your back strength, and that leads to postural changes, which makes you slump forward. Even if it's by a little bit, that can still be part of that whole storm that creates a situation by which bursitis can be triggered off pretty easily. So let's just go back and talk about why I believe that cortisone in the context of bursitis in the shoulder can still be a valid treatment tool even if you're at risk of lymphedema. The biggest caveat with this section of the video, guys, is that if you go and get a cortisone injection on the arm where you've had lymph nodes removed, which means you're at risk of lymphedema, you really want to make sure that your radiologist who's performing that injection is aware of those facts. So make sure you have that conversation even before you get to that appointment. That will just make sure that the team that's performing the injection, or the radiologist that's performing in the injection, is just being extra careful with infection control when it comes to that injection. But then on top of that, also that they are taking extra care when they perform the procedure. So we want to avoid infection, number one, but we also want to avoid any needle stick injury. Now, a good radiology clinic, that doesn't happen, generally speaking, or if it does happen, it's so incredibly rare. And this is why I talk about this topic in a lot of detail, because to me, it's a risk-benefit ratio. If we have a patient who's got breast cancer and then they've then they've got bursitis in their shoulder, we've got to look back to, well, what is the nature of the lymphatic system and where's the risk of lymphedema? So if you cut an artery, it will spurt blood, okay, because the heart is pumping behind that arterial system, and the pressure of the part pumping will cause a cut artery to spurt blood. If you cut a lymphatic vessel, it will trickle. That's because there's no major pumping mechanism behind the lymphatic system. So if you think about that, the only thing you've got to rely on for the lymphatic system to flush itself out is muscle contraction, movement, and a little bit of gravity. So if that's the case, then moving your limb is really, really important for getting lymphatic flow going regularly. So one of the things we like to see patients who are at risk of lymphedema, or those who have lymphedema, doing is exercise, movement. We certainly don't encourage people to sit still all day if they're at risk of lymphedema, because as you can imagine, sitting still is not going to be helping the lymphatic system flush away. So on that note, if you've got someone who's got a really sore shoulder because of bursitis, the last thing we want to do is leave that person with a permanently injured shoulder by which they can't move their arm freely, because then their lymphatic flow is not going to be moving on a regular basis, which, as far as I'm concerned, with the anatomy and physiology of the lymphatic system as I just described it, that's not going to be a good thing for that patient. So in the case that we can do a controlled cortisone injection with good infection control procedures where the patient's being educated, I believe that a cortisone injection in the context of bursitis, even with someone at risk of lymphedema, is a worthwhile procedure to do. But you've got to have all of those things in place before you go ahead to do a cortisone injection. Of course, there's patients who go, you know what, I'm just going to try the physiotherapy option for a little while and I'll see if my shoulder gets better. And people are more than welcome to do that. They can try every alternative option they want. It's just that in my clinical experience with bursitis particularly, I think for pain control and getting on with getting the shoulder moving and strengthened, cortisone is the first best thing you can do. Let's just quickly talk about when it's a good time to avoid a cortisone injection, because there are times when doing a cortisone injection is probably not the best idea. It could be when you're immune suppressed. So if you're coming through treatment, or you're just on the tail end of treatment and your immune system's really still playing catch up, it may not be a great time to shoot off and do a cortisone injection if your immune system is really low. So consider that time. And of course, you know, one of the biggest times your immune system is at its lowest point will be through chemotherapy, or even, you know, after chemotherapy and leading into radiation. So if you can wait out those periods, even if you know you've got something like shoulder bursitis going on and then you're leading, you can get your treatment done on the other side of those things when your immune system's picked up a little bit. That might be a good time to wait until you need to get the cortisone injection done. Thank you so much for watching this video, guys. I hope you are having a fantastic week wherever you are. Happy New Year to everybody. Can't wait to talk to you more through 2021. We've got so many exciting things coming up for the Breast Cancer Physio channel, so I'll keep you posted on all of those. If you have any questions about bursitis or shoulder pain, leave a comment in the section below. I'll be bringing out a video every week, as I have done, so keep me posted on any topics you want me to cover. I will see you guys next week. I'm Jen McKenzie, the Breast Cancer Physio.